Hello, this is Mental Health 5. In this episode, I'm going to talk about medications and mental health. And I have some expert advice from a renowned researcher, Dr. Stephen Hollon. So stay tuned. Hello, this is your host, Dr. Suzie Dukic. Welcome to Mental Health 5. Let's talk about medications. Recently, I had the pleasure to talk with Dr. Stephen Hollon about the brain and how it adapts to survive. We also talked about medications and mental health. In this episode, I included a small part of that interview where Dr. Hollen discusses medications. You can hear that interview in its entirety in a future episode called The Brain Adapting to Survive. Before my discussion with Dr. Hollen, I wanted to give you some of my insight as a professional counselor regarding medications. So, if I have a client come in to see me and they can't sit still in the chair, their eyes are darting all over the room, they're very nervous or uncomfortable. Part of that can be expected because they don't know me, and who knows how long it took them to build up the courage to make that appointment and actually show up with a total stranger to share their struggles. And so once I get a medical history, and I'm not a medical doctor, but I ask questions like, when's the last time you saw your primary care physician? Do you have any medical conditions? That type of thing. And if it's been a while, I'll suggest they go and just get a physical. Just get checked out because, as I've said in previous episodes, there are some mental health symptoms that are caused by physical health issues. And so I think if it's been a while, it's important for a client to see their primary care physician. And so after we discuss that, and then I ask them if they've ever had any medications for their anxiety or depression or whatever symptoms. And some are receptive and open to a suggestion. Others, they may have an addictive personality, and they'll tell me that. Oh, no, I've partied too much, or I know I struggle with self-control in my younger years. I really don't want to take anything. And so oftentimes I'll suggest that they talk to their primary care provider, tell them the symptoms they're having, and if it's mental health, then request that the primary care provider refer them to a psychiatrist so that they can get some medications. Now, here's why I might suggest that. I don't do that with every client. If the client is struggling to focus on the words I'm saying and maybe on the feelings or the thoughts that are coming up, if they're really struggling to be present, then I might suggest that they talk to a psychiatrist or get a referral from their primary care physician so that they can get a medication to take the edge off of that anxiety and help them focus and be more present during talk therapy. And in my opinion, folks, the ideal situation is this. And this is a scenario where I think a person might need some medication to help them with their talk therapy. Ideally, so a person goes to their primary care provider and they get some blood work and tests and find out that they're okay physically and the symptoms aren't being caused by a physical ailment. So the primary care physician then refers them to a psychiatrist. This could also be a psychiatric nurse practitioner or a physician's assistant, and these two professionals work under the supervision of a psychiatrist. And so they go and they are diagnosed and prescribed some medications to help with their anxiety or depression. And then they're also attending talk therapy. And so there's two things they're using there to help themselves grow and be better. And so, again, back to the ideal situation. They get on the medications. Most medications, it takes 10 days to 14 days for the patient or client to actually feel an effect. Sometimes it's a little sooner. Sometimes it takes a little longer. And again, that's something that they would discuss with their medical doctor. So after about 2 weeks, maybe they start to feel better. And at the same time, they're doing therapy. either weekly or bi-weekly. Typically, when I start with someone, we start out weekly so we can kind of build that therapeutic relationship, and also so they can start feeling comfortable with me, and start really being intentional on the work they want to do with themselves or for themselves. And so let's just take a scenario. They work for 2 months. They're on their medication. The first 4 weeks, they may be doing weekly sessions, and then they're feeling better, and they're applying what they've learned in their world, not necessarily in a counseling session, but they're actually making change in their own personal world. And so they're working along, and they're starting to feel better. They're starting to set boundaries or pay attention to their negative thoughts, or learning techniques to ground themselves when they're feeling really anxious. And so they're being intentional with their therapeutic techniques they're applying in their personal life, as well as taking their medication as prescribed. And so they start doing better. And so I wouldn't suggest they get off the medications right away. Maybe they wait. This is different. It would be different with each client. And so eventually, with no timeline discussed here, they would talk to their physician, their psychiatrist or prescribing physician, and start titering or pulling back off the medication. So we don't just stop mental health medications just because we feel better and we're done. This could be very dangerous for your brain, for you overall. So you need to the help and support of that doctor. And so you slowly titer or lessen your daily dosage, and you're still doing therapy. And so you slowly pull off that dosage until you're off the medications completely. And that may be something that takes a year. It may be something that takes 6 months. It could be 2 years. Again, each individual is unique, and this would be a process that you would be working with that physician. And so back to the perfect scenario, or not perfect, my idea of an ideal situation involving medications and therapy. So the client / patient slowly weans off the medications. They're still going to therapy, but now they're doing better, and maybe they're just doing monthly check-ins with their therapist. They're not just stopping therapy abruptly either. And so now they're building up confidence with their new skills and applying those in their personal life. They're feeling better. They're making positive change. They've slowly weaned off the medications. They're now on a maintenance schedule with their therapist or counselor or other mental health provider. And then eventually they wrap up their work with the therapist. And so to me, that would be a nice situation, a healthy situation, a slow-paced situation for how medications and therapy might look together and work together, involving the mental health provider as well as the prescribing psychiatrist and the client. The client's the one doing all the work here. Just so you know, I know I say this before, but the therapist and the physician are not doing the work, the client is. They're just using that collaboration and all that help to help themselves be better and take care of themselves. So now I would like to move on to an excerpt from an interview I did with Dr. Stephen Hollon. We were talking about the brain and adaptation, how our brain changes to help us adapt in our world. And I really wanted to ask his take on medications. And so I'm going to do a quick bio, tell you a little bit about him, and then we're going to dive right into a little piece of that interview. And then be sure and be on the lookout in the future, because I'll have a full interview in a future episode where we talk about the brain and adaptation. So here's that bio and a wonderful excerpt with Dr. Hollen. Dr. Stephen Hollon is a professor of psychology and psychiatry at Vanderbilt University in Nashville, Tennessee. He is also faculty with the psychiatry department at the University of Toronto, as well as several other academic and clinical collaborations. He is renowned for sharing his wisdom in research collaborations with psychologists and other mental health professionals in the United States and throughout the world. His work is characterized by a balanced approach to the interplay between psychological science and the clinical practice of evidence based treatment. Okay, so so this is your final statement's a great segue into what else I'd like to talk about, some medication and therapy. When you work with clients, you are teaching them skills to change that negative part, right? Okay. And so, and I've read some research, can't cite it here off the top of my head, but actual brain changes have been observed when people have undergone talk therapy. Specifically, your expertise is cognitive behavioral therapy, also known as CBT. Okay. I think it's, when I tell clients that primarily I work with anxiety more than depression, that they can change the way their brain is functioning or wired or their thought patterns. It is amazing to me the hope that I see in their eyes. And it's kind of like, I'm not crazy. I'm not just this crazy person and all these crazy thoughts in my head. And I'm just out there. You actually kind of empower them on some level. They do all the work. We don't do it. But being able to tell them, no, there's some science to show once you can start changing your thought patterns and there's more specifics to that. But once they can start moving toward change with how they perceive themselves and the world, then actual changes start happening in the brain. Okay, great. I just find that amazing. So some people, they go to the doctor, they're not feeling well, and either their primary care physician or they've been referred to a psychiatrist, for depressive thoughts. Okay. They hadn't been diagnosed yet. They're just down. And so I find this happens often with primary care physicians who aren't really trained in that. They're trained. I don't want to take anything away from that. But maybe they haven't received a proper diagnosis, or maybe they have received a diagnosis and the first line is, here, I'm going to write you a prescription for some medications. And I'm not going to get into the detail of all the medications because it's too complex, but the patient or client gets a prescription of medication, they get on that. And what's frustrating to me as a therapist is that oftentimes they're not therapy is not recommended to them. It's more of a medication management relationship with that physician. And, I don't know, I think it's not going to fix anything. It's more like you said earlier, it may alleviate the symptoms and they feel better, or their mood has regulated. It's not all over the place, or it's not way, way low or down. And so they feel better. It's like, okay, I've talked to too many people. I don't need therapy. I feel good. This is all I need. This little pill, and it has changed my life. So I'd like you to speak a little bit to medications and then your perspective on therapy and medications.
That the antidepressant medications are actually pretty good medications. They're not addictive in the classic sense. They don't have particularly problematic side effects, and they do work. So, if I get a headache, I take an aspirin. So I have no problem with anybody if they get depressed wanting to relieve the distress. If there is a downside, it works in the following way. Most prescriptions, about 90% of the prescriptions for antidepressant medication nowadays are written by primary care physicians. And they're marvelous at picking up things that'll kill you, but they're not necessarily that well trained in psychiatry, as you were mentioning. Psychiatrists tend to be a little more cautious about prescribing antidepressants, not because there's anything wrong with them, just because they know that there are other options available. And I think I used the example earlier of taking over-the-counter remedies. If I've got the flu, it will help me feel better sooner, but it will perhaps prolong the length of the underlying episode. And there's some reason to think that the medications, as effective as they are in the short run, may be hard to stop in the long run. So that you, at the very least, you've done nothing to change your propensity for getting depressed in the future in the ways that some of the psychological interventions can do. Cognitive therapy cuts risk for future episodes by more than half. Behavioral activation probably does the same. Interpersonal psychotherapy, we don't know whether or not it reduces risk. We do know it improves quality of relationships. And people just do better jobs in their relationships after IPT. And all of the major tested psychological interventions are as effective as medications in the short run, and either have longer term enduring effects or do other things that people like in addition. The way I would the way I would think about that is that, gee, the medications are useful. I would myself not want to start there. I would go there because our evidence suggests about 1 person in 3 who gets depressed is not going to respond to the other psychotherapies. But I would start with one of the reasonable psychotherapies and only bring the medications in if I needed to. There's a principle in evolutionary medicine, which is anything which facilitates the function that uh, an adaptation evolved to serve is going to be better in the long run than something that simply suppresses the mechanisms. And the anesthesia helped the squid not feel the pain, but made it more likely they got eaten by the sea bass.
Okay, and so that comparison is if we just take the medication and not be trying to change the way we think with therapies, then we are more apt. It's just kind of putting a Band-Aid on it. We're more apt to have another recurrence of depression. We're not growing
I think
and
it's a very
learning,
fair
in other
summary.
words.
And again, I'm not opposed to Band-Aids. If
Okay.
I'm bleeding, I at least want to staunch the
Yeah.
wound. But there may be other alternatives that do as good a job that get you other things as well.
Yeah, and one metaphor I use with regard to the Band-Aid is I'll say, say you have this gash on your forearm, you see it, and you don't wash it and clean it and put antibiotics on it. You just slap a bandage on it, so it quits bleeding and you've temporarily stopped. But in order for that deep wound to heal, it needs to be nurtured. You need to cleanse it. You need to put antibiotics on it. It needs, there's a process on how that injury heals, and it takes time, and there may be a scar there, but the person can learn, okay, I'm going to be more safe when I'm working with dangerous equipment because I injured myself last time, but I took steps and nurtured and healed that injury. So it's hard for a lot of our listeners to understand that trauma and a depressive episode or something bad happening to us in our life, we can't just put it away. It is like a wound and it needs to be healed. And what medications can do is alleviate those symptoms, like you said, and help you feel better. But also, back to the Band-Aid, maybe we need the antibiotic to help the wound heal completely, which in my view
You
would be
might well have
therapy.
multiple options, and it's good to know what each of them does. Yeah.
Yes, multiple options. And so now, in just as we're getting close to wrapping up, I'd like to get some of your insight on cognitive behavioral therapy. We know that there's several behavioral therapies, and there's no time to go into all of them here, but I know your expertise is in cognitive behavioral therapy. And you say in one of your articles that CBT has an enduring effect that protects against relapse. Now, I know we've been talking about it a little, but could you speak to that specifically, why CBT can help with preventing relapse?
There are at least 8 well-done randomized controlled trials in the literature that have compared prior cognitive therapy to prior medication treatment. And on average, they about comparably effective in helping people get over depression. Neither works for everybody, but they work more often than not. But if you get better having gone through cognitive therapy, you're less than half as likely to have a subsequent episode as people that get better on medications once you stop the treatments. And it's 7 of the 8 trials confirm that. It's one of the best established findings of the literature. We think the reason that's so is what we do in cognitive therapy is not simply focus on the particular beliefs a person has when they're depressed. We also go with the kind of things we think they walk into adolescence, being prone to believe about themselves, that I'm unlovable, that I'm incompetent, etc. For most people, that's simply not true, but they get stuck there. So we think that we not only address the stuff that's making somebody feel bad at the moment, but the stuff that got them feeling bad in the first place. But it's always a little harder to prove that, but that's basically what we focus on.
Yeah, that it's similar to, CBT is my first line of treatment with anxiety and relationship, but Then I call it dropping below the neck.
Mhm.
Then we go a little deeper and look at the messages one receives in their environment coming up. Because the messages, often they're implicit messages. It's just how we
Mhm.
develop our
Yeah.
sense of self and our professional identity, and it's perception of the self. And that's one of the things that I've worked hard on, is helping. We can't change the past, but
Yeah.
we can change our perception
Yeah.
of the past, actual events, and we can change our perception of us. If it's negative and we
Yeah.
feel unworthy or invisible and not good enough to fit, then we can help a client work on changing those ideals and those thoughts, those messages they received. And it doesn't mean parents are bad. It's just, I don't know if anyone that's had a perfect childhood. So even parents with good intentions, we can receive messages that affect our perception or
Mhm.
positive
Yeah.
perception of
Yeah.
ourselves.
Yeah.
And
I guess, excuse me, I cough here. Absolutely. I think you're absolutely right about all of that. And parents may have been giving very reasonable messages. We can, as pre-adolescents, we can certainly put two and two together and come up with five. And there's a tendency for people to
yeah,
particularly look for reasons if they're not that happy. And oftentimes, at least the people we're most likely to see clinically with depressions are people that concluded that there was something deeply wrong about themselves. And they may not have ever heard that from their parents. They may not have heard
yeah,
that from their friends, but that's the wrong inference they draw. That's the primary thing that, at least in cognitive
right.
therapy, we try to help people get past.
Yeah, yeah. And I think, yeah, getting people past that, it can help them start being more positive in the present time. So I think it is good to explore some of those messages and why we're the way we are. And it doesn't mean we had terrible parents. It just means that's what our perception developed, our perception of ourself. And so thank you for elaborating on that. And so I'd like to wrap up, Dr. Holland, today. We have many listeners out there that are on medications. And so, is there a final thought or a final message you would like to share with our listeners concerning therapy and medications, either or
Yeah,
and both?
basically, again, we know the medications are good, they're effective, and if they're working for you, I would not want to talk anybody off of the medications. On the other hand, there's no clear reason why somebody needs to be on medications a lifetime unless they're in the bipolar spectrum. If you're in the bipolar spectrum, please, please, please get on lithium or a mood stabilizer and stay on if you've a propensity for psychotic depressions or manias. But short of that, if it's unipolar
Mhm.
depression, you probably have alternatives available. But I would only, if I were even going to consider stopping medication, I would only do that in conjunction with a good psychiatric input. And I'm a big fan of primary
Okay.
care physicians, and I go see them to keep me alive. But those aren't the folks who are experts on antidepressant medication. Psychiatrists are.
Yes, and I would agree. That's what psychiatrists have extra training in that, and they understand, and they also have training in diagnoses of the mental health disorders in the DSM-5. So they have training about our mental health, and primary care physicians. They may have some training, and like you said, primary care physicians have their role, and we need them. But do consider, if you would like to have questions about your meds or go talk to someone about meds, do reach out to a psychiatrist or
Yeah,
your primary care provider.
they're
Ask them
usually
for a
more than happy to.
referral for a psychiatrist.
Again, if I had
Yeah, yeah,
any kind of heart condition, my primary care physician would immediately send me to a specialist. If I had what
exactly.
they thought was asthma, which I may do or may have, my primary care physician sends me to a pulmonary expert. So primary care physicians are marvelous at detecting things that need additional input, and they're also very good at getting you to somebody who'll give you that additional input.
Exactly. And that's a great way for me to wind up and go back to that band aid metaphor, that if Dr. Holland's heart is acting up or not beating in a rhythmic manner, he's going to be referred. They have EKGs, things they can hook up and say, okay, we need to have that heart checked out. And so it's not often that clear and black and white with mental health. So if you're struggling with dark thoughts, it doesn't mean you're crazy. Go talk with someone or reach out, because there is a wound somewhere, or there is a maladaptive behavior or thought pattern where there are treatments out there, medications, therapy, the combination, and there's various types of therapy. But do keep that in mind. It's still a condition. It's just not as obvious as something that might be on the outside. That's all I have on medications and mental health. I hope that this information will help you better understand the role medications play in mental health. In my next mini-series, we'll explore where it all takes place, the brain. So hit that follow button and be on the watch for the mini-series called The Brain and Mental Health. Until then, I wish you peace and good mental health. This episode is brought to you with help from my IT support, Suzie Dukic, and Scott Holmes Music for my theme song.